Good afternoon, everybody. My name is Arjun Nambiar, and I'm a urology trainee from the UK. And these are my disclosures. So botulinum toxin, I think we all agree, is one of the standard established treatments for overactive bladder, whether idiopathic or neurogenic. In the early days, it was done under general anesthetic, but nowadays it's more commonly done under a local anesthetic with a flexible cystoscope. At our center, we use standard lidocaine gel as the local anesthetic of choice, but we found that some patients were still experiencing significant discomfort when using this type of local anesthetic. And then we came across the work of Curtis Nichols' group here in Canada, who said that alkalinized lidocaine is better at providing anesthesia compared to lidocaine gel in patients with painful bladder syndrome. So we thought perhaps this could translate into better anesthesia for bladder injections as well. So our question was, what is the comparative efficacy and morbidity of alkalinized lidocaine compared to standard lidocaine gel for intravesical anesthesia prior to botulinum toxin injections? And to answer it, we set up a randomized control trial of 54 patients, powered at 80% to detect a 20 millimeter mean difference in visual analog scale score for pain between the two groups. And the composition of the solutions is, as you can see here. The first group, the alkalinized lidocaine group, received 10 mils of 8.4% sodium bicarbonate plus 20 mils of 2% lidocaine as the active component, mixed with 22 mils of sterile aqua gel for double blinding purposes. The lidocaine gel group received 22 mils of 2% lidocaine gel as the active component and 30 mils of normal saline for double blinding purposes. Either solution was instilled via an intermittent catheter at least 20 minutes before the injections took place. Baseline characteristics, as you can see, were not significantly different between the groups, although numerically there were a few more patients in the lidocaine gel group who had had previous Botox injections, botulinum toxin injections. The results of the visual analog scale scores, as you can see, were not that different between the groups, apart from a few outliers, which is almost inevitable when you're assessing pain scores. But the mean in the alkalinized lidocaine group was 17.11 millimeters, and in the lidocaine gel group, 19.53 millimeters, with no evidence to suggest a significant difference between the groups, with p-value of 0.656. However, the cost of alkalinized lidocaine was found to be almost double that of lidocaine gel per patient per installation. No adverse events attributable to the anesthetic were found in either group. So in conclusion, based on this study, we conclude that alkalinized lidocaine, at least there's no evidence to suggest that alkalinized lidocaine is any better than lidocaine gel for anesthesia prior to intravesical botulinum toxin injections, and the higher cost precludes its use over lidocaine gel at our center. However, we do recognize that we did not map the patient's pain during the procedure, so because of the difference in characteristics of the solutions, it is possible that the distribution of pain is different between the groups, but we could not assess that in this study. Thank you very much. Any questions?
You were talking about Curtis Nichols' work with Richard Henry up in Kingston. What they actually did was to put lidocaine in first, then apply a bicarb chaser afterwards, with the idea being that the in situ lidocaine would then go to be the apolar form and therefore go across the urothelium. I think you were mixing it up beforehand. And that might be a problem because it could come out of solution, because as you know, when you normally get lidocaine, it has a low pH and it's in the polar form. And once you mix it up, it may come out of solution. So that's maybe why you weren't gaining an effect in your study.
That's interesting. No, thanks for pointing that out. I mean, the background sort of reading that we did didn't really bring that up, but thanks for pointing it out, because you're right. It may be part of the reason why we didn't see a difference. But in terms of contact time, 20 minutes in both solutions. So you're right. If mixing it together in solution putting it into the patient actually makes a difference, then it could possibly be the difference. And
you didn't have a double dummy group, so I was wondering, I mean, is this stuff actually working adequately? What would it be like if you had no treatment for analgesia? What kind of pain scores would you be getting on a VAS?
I don't know the exact answer, but this is anecdotal, because we used to do this with contact times of perhaps maybe less than 5 minutes, or sometimes under with a rigid scope as opposed to a flexible scope. And we found that patients were significantly having more pain when the contact times were less, and also when we were using rigid scopes. So, I mean, I don't know if anybody would allow you to do a study without giving anybody anesthetic of any kind, but that's the anecdotal evidence that we have.
Thank you, sir.
Aaron Sahaya from Guy's in London. A question I had really is generic about installations. I mean, particularly relevant for Botox because if we're doing, and I'm assuming you're doing non-trigonal injections,
Yeah.
is it important about the surface area of contact? And if you're only putting in 20, 30 mils, are you going to get the coverage in the bladder to help?
No, that's a good point. I mean, we did empty the bladder in everybody before we did this. That's the first thing. So the bladder is empty and collapsed, if you like. But I agree that perhaps if you have more volume of solution and better contact, therefore the effects could vary. I mean, it also points to the difference in the characteristics of the solution. If you, in this case, we're using gel and liquid in both cases. But if you're doing it just with alkalinized solution, and in the other group, if you gave just gel, which is what we normally do, is standard instiller gel, the contact could potentially be very different.
Do you have any experience, or is there anything in the literature about that volume? Does it make a difference, or we don't know?
We don't know. It's the standard that Allergan, I mean, the Allergan are not very prescriptive about what anesthetic you use, which is partly the reason why we did the study, to see which is better. But you're right, volume could certainly make a difference.
Test, yeah. Matt Fraser, Duke University. So my question is, do you ever get areflexia just from the installation after 22 minutes? I mean, do you know?
No, we didn't experience.
Like that?
No, thanks for your question. No, we didn't experience that in the study, and out of study as well. We've never experienced that in our center, so it hasn't been a problem for us so far.
Thanks.
Okay, thank you very much.
Thank you.
Thank you.